Hello, my name is Dr. Anne-Marie Buckley and I'm a paediatric registrar. I'm going to talk to you today about fever in children. We're going to start off with a definition of fever, have a brief look at the fever physiology, pathophysiology, look at fever phobia, look at the impact of fever on the health service, and then we're going to spend the majority of this talk looking at the NICE guideline on fever in under 5s, and then we're going to finish off with a conclusion. The definition of fever, according to the NICE guideline, is actually a physiological definition, so it's an elevation of body temperature above the normal daily variation. However, they appreciate it can be hard to define, as normal body temperature varies depending on the individual, the body site where the temperature is measured, and the time of day. Therefore, they also agreed that a temperature of greater than 38 degrees represents a temperature. Also, that the entry point into the use of the guideline on fever in children under 5 should take into account both a measured and a reported fever, acknowledging that a lot of parents don't have or use a thermometer. Look briefly at the pathophysiology of fever. So we know that microbes and microbial toxins act as exogenous pyrogens, and we know that these stimulate the release of endogenous pyrogens, including cytokines such as interleukin-1, interleukin-6, tumor necrosis factor, and interferons. These cytokines are, of course, released by monocytes, macrophages, glial cells, and B lymphocytes, all important cells of the immune system. And that, if you look at number 1, these pyrogens lead to a resetting of the thermostatic set point of the anterior hypothalamus, and this is done by leading to liberation of arachidonic acid, which is metabolized to prostaglandin E2, and that acts on the hypothalamic thermostat, and you end up in position 3, where you get temperature raising responses, so you get vasoconstriction, shivering, piloerection, and increased metabolism, which leads to fever. Fever then feeds back to number 4, where you end up with a core body temperature reaching a new set point, and then you end up at position 5, where you end up with temperature reducing responses through vasodilatation, sweating, and increased ventilation. So fever phobia, this was a term that was introduced in 1980 by Schmidt to describe parents' misconceptions and anxieties about fever. We know that it still persists today, many years later, and the fear of fever amongst parents can be influenced by their ethnic background and also by their cultural beliefs. The topic has been well studied, with a number of authors conducting surveys. One was studied was done in 2013 by Teagle and Powell in Wales, which was a single centre cross-sectional study, a very simple study, which was of about 70 to 80 parents who were seeking healthcare at the local hospital, and they found that parents had strong beliefs about fever and had low thresholds for seeking medical advice for treating fever. Their main concerns included dehydration, seizures, brain damage, coma, or death of their child. We know that combined use of antipyretics is common, and in this study it was reported in 50% of patients. Cold sponging and tepid sponging still happen, despite the evidence being that they're of no benefit. Also, worryingly, parents reported using antipyretics much more frequently than the recommended dosing schedule. 40% were using them more than the recommended 6 hourly, and about 6% more than 4 hourly. The study also pointed out that medical and nursing staff are the biggest source of information about fever, which is obviously of huge importance in terms of our ability to do primary prevention and educate parents, but staff misconceptions exist, which also may contribute to the problem of fever phobia, with our own inherent concerns and attitudes about fever. It's also important to consider whether we should be lowering fever at all. as there is emerging evidence that fever itself forms part of our effective immune response and may actually help our specific immune cells to function better. In particular, CD8 plus cytotoxic T cells have been widely studied. And so the question is whether we should be promoting antipyretic use in mild to moderate fever in particular. Children with fever have a big burden on the health service, with about 20 to 40% of parents reporting a feverish illness in young children each year, according to NICE. We know that young children, especially those in the first 18 months of life, have a number of infective episodes per year. We know that it's probably the commonest cause for a child seeing a doctor, and it's the second commonest reason after breathing difficulty for admission to hospital. And unfortunately, it does still remain the leading cause of death in children less than 5. So a febrile illness really does present a diagnostic challenge. And the main problem is, how do we pick out those serious bacterial infections, which are obviously not very common, from the incredibly common viral infections, which will undoubtedly be self-limiting. There are a number of serious infections that we obviously should be worried about in children with fever. So pneumonia, septicemia, UTIs, meningitis, septic arthritis, osteomyelitis, other bacterial infections, encephalitis and Kawasaki's disease. We estimate that about 1% of children aged 0 to 5 may have one of those serious infections each year. However, we know that there's quite a large variation in the estimated incidences depending on the source of your data that you use. We have to think about how we can improve on our morbidity and mortality from serious bacterial infection, and obviously very successful vaccination programs are of paramount importance. Alongside this, we should be developing and using clinical guidelines to guide doctors in the management of the febrile child, and it's actually a requirement of the Children's National Service Framework, which sets out the government's quality standards for children and young people and maternity services, that children should have access to high quality, cost effective, but also evidence-based care. Now, if we look specifically at the guidelines, so it's for fever in under 5s, assessment and initial management. And it's for those children with no obvious cause of their fever. And the aim of the guideline is to improve the clinical assessment and help healthcare professionals diagnose serious illness amongst young children who present with fever in primary and secondary care. The initial guideline was in 2007, and then they published this updated version in 2013. This is Clinical Guideline 160. There have been 2 evidence updates since then. There was one in February 2015. However, that didn't replace the 2013 guideline, but it was intended to increase awareness of new evidence. And then there was an update in April of 2017, and they added in a couple of recommendations after that update. It's important to remember that this guideline should be used in conjunction with other guidelines, such as the bacterial meningitis one, the urinary tract infection, diarrhea and vomiting, and also that once a diagnosis of a specific infection has been reached, then we should be moving on to using national and or local guidelines for that management of that specific condition. Also important to acknowledge that this is a guideline, and that the training and experience of the healthcare professional involved will ultimately dictate how they interpret the guidance according to the scope of their own practice. Briefly at the methodology for the 2013 update of the guideline. So the scope for the update was identified areas where substantial new evidence was available. And then on the basis of that, the reviewers formulated these review questions based on that scope and prepared a protocol for each review question. And these questions formed the starting point for their systematic reviews of the relevant evidence. They looked at published evidence and they applied systematic search strategies to 4 the Medline, Embase and 4 Cochrane databases. And they also, if they were looking at economic studies, they also included the NHS Economic Evaluation Database. In most cases, they limited the search according to date, and for Medline and Embase, they limited to English language and human studies, and they didn't look at grey literature or they didn't hand search any articles. In terms of evidence synthesis, they used the GRADE system, which is a well-recognised system where standing for Grading of Recommendations, Assessment, Development and Evaluation approach, and this is to help them come up with a assessment of the quality of the evidence. So there's 6 points that they evaluate: so study design, limitations in the design or execution of the study, inconsistency of effects across the study, indirectness, imprecision, and then other considerations. And they gave an overall quality rating as high, moderate, low, or very low. And that's assigned by obviously combining the number of different ratings for the individual factors. And then it's important to also understand that there wasn't, for a lot of things, there wasn't actually evidence to help them make the decision, so they used something called a Delphi consensus. And this was basically where they had a 2-round Delphi consensus method to derive recommendations for important clinical questions where no substantial evidence existed. And this involved the participation of over 50 clinicians, parents and carers from appropriate stakeholder organisations. And they rated a series of statements presented by the committee using a scale of 1 to 9 as being either strongly agree or disagree. So they came up with a number of recommendations on the following topics. So looking at thermometers and fever detection, clinical assessment of the child with fever, management by remote assessment, management by non-paediatric practitioners, management by paediatric specialists, antipyretic interventions, and advice for home care. And we're not going to cover all of this in detail because it's a 310-page document, so it wouldn't be possible in the short space of time we have, but we're going to touch on a few important points. So looking specifically at the use of thermometers, which is a question that paediatric doctors and nurses get asked quite a lot about, the NICE guidance is that we should not routinely use the oral and rectal routes to measure the body temperature of children aged 0 to 5, and that was reached through a Delphi consensus. Looking then at the other methods of measurement of body temperature, they recommend in those less than 4 weeks we should use an auxiliary electronic thermometer. And in those 4 weeks to 5 years, we should either use one of the following recommended methods. So an electronic thermometer in the axilla, a chemical dot thermometer in the axilla, or infrared tympanic thermometer. They weren't able to give a recommendation on each of the 3 of these, as there was a specific recommendation, as there was no comparison studies available to recommend one type over the other. However, data from neonates does suggest that the auxiliary thermometer measurements are slightly more accurate, and therefore that's why they are recommended in that group. Another question that raises an issue often is whether or not tympanic measurements are reliable less than 3 months. They put this to the Delphi panel, but unfortunately they couldn't come up with a consensus, and so therefore they couldn't suggest an age limit on the use of tympanic thermometers. And then a couple of other points is that if a healthcare professional is routinely using disposable chemical thermometers and multiple temperature measurements are required, then they should probably think about using an alternative type of thermometer. That was primarily on the basis of economics. And then a reminder that forehead chemical thermometers are unreliable and should not be used by healthcare professionals. An interesting point is that on the subject of subjective detection of fever by parents and carers, and actually the NICE guidance states that reported parental perception of fever should be considered valid and taken seriously by healthcare professionals. It's actually relatively well studied, but unfortunately there are no UK studies. In the studies, the sensitivity and specificity of detecting fever by palpation were comparable with those reported for auxiliary and tympanic thermometers. They therefore state that actually detection of fever by palpation was probably as good as the other alternatives to oral and rectal measurements. Moving on to the clinical assessment of the child with fever, The first recommendation is that we should identify any immediately life-threatening features, looking for compromise of the airway, breathing or circulation, and decreased level of consciousness, and always think, could this be sepsis, and cross-refer to the sepsis guideline as needed. That was a recommendation that was added in 2017. So then if we look at one of the main features of this guideline is actually the use of the traffic light system, which helps to assess the risk of serious illness. So the traffic light system existed in the 2007 guideline, where the evidence-based reviews were undertaken to identify the relationship of individual signs and symptoms and the likely presence of any serious illness. The members of the guideline group then used their own clinical experience to assign these signs and symptoms to the green, amber or red column. And then evidence-based reviews were undertaken to identify signs and symptoms of specific serious illnesses. The process differs slightly in the 2013 update, where they focused on the diagnostic usefulness of signs and symptoms, focusing on the correlations between symptoms and serious illness. Therefore, the updated reviews essentially act as a validation of the original traffic light table. So as you can see from the traffic light system, I'm sure most people are familiar with looking at this and have seen it before. It's divided into 3 columns: green, low risk; amber being intermediate risk; and red being high risk. And then there are 5 main areas within which the signs and symptoms are allocated. So you've got colour, which is of the skin, lips or tongue; activity of the child; respiratory function; circulation and hydration; and then other. The Guideline Committee then painstakingly reviewed the evidence for each of the 21 signs and symptoms, either alone or in combination, and they actually identified 7,977 records and included 59 studies, and they looked at these specific points. So they recorded the number of studies, the number of children, then they looked at the sensitivity, specificity, positive predictive value, negative predictive value, positive likelihood ratio, negative likelihood ratio, and also the quality of the study. They did make a couple of changes to the traffic light table. In the 2013 update, they removed a new lump greater than 2 centimetres and bile stain vomiting, as basically there was no evidence reported on the use of this sign and symptom to detect serious illness. And then they made a couple of changes. So they moved the temperature greater than 39 degrees in a baby 3 to 6 months old from the red column to the amber, and they added in rigors and tachycardia both to the amber column. And this is just a reminder of the table itself. So again, from their evidence review of the signs and symptoms, they were able to come up with this list, which was basically that these are the children who are in a high-risk group. So if they have any of the following signs or symptoms, then they're in a high-risk group for serious illness. And I'll let you read those for yourselves. This was new evidence that was reviewed, and the recommendation was updated in 2013. And then they also had a statement that basically if a child with the following features and no high or intermediate risk features, then they would be in a low risk group for serious illness. Again, that was a new addition in 2013. A couple of other points were that they recommended that in children older than 6 months, we shouldn't use the height of body temperature alone to identify those with serious illness. We should recognise that children younger than 3 months with a temperature of 38 or more are in a high risk group for serious illness. We shouldn't use duration of fever to predict the likelihood of serious illness. However, a child with a fever more than 5 days should be investigated and assessed for possible Kawasaki's disease. This was a new guideline, a new addition in 2013. And also we should recognise that children with tachycardia are in at least an intermediate risk group for serious illness, using the APLS criteria for defining tachycardia. So we should also be aware of the specific signs and symptoms which lead us to think about specific illnesses. But we must be aware that the classic signs of meningitis, so neck stiffness, bulging fontanelle and high-pitched cry, are often absent in infants with bacterial meningitis. We should be considering herpes encephalitis in children with fever and any of the following three features, so focal neurological signs, focal seizures or a decreased level of consciousness. We should be considering UTI in a child less than 3 months with fever. And if you have a child with fever, you should always inquire about travel abroad to try and identify imported infections. So looking at some of the recommendations for management by the non-paediatric specialists, they reviewed the evidence for chest x-ray use routinely in children with pneumonia, and those with signs and symptoms of pneumonia who are not admitted to hospital should not routinely have a chest x-ray. And this was through looking at a systematic review of chest x-rays in children, including a randomized controlled trial. They also recommended that we should be testing urine in children as per the NICE clinical guideline. Looking again at the response to antipyretics, we shouldn't be relying on a decrease or a lack of decrease in temperature to differentiate between a serious and a non-serious illness. And again, that was an additional recommendation added in 2017. Then we move on to treatment by the non-paediatric practitioner. And NICE do not recommend prescribing oral antibiotics to children with fever without apparent source. And this is because 97% of well-appearing children with fever do not have an occult bacteremia, which is essentially what you would be trying to treat. Therefore, they will not benefit from oral antibiotics empirically. They looked at, basically, there were 3 studies of antibiotics in children with fever but who were well, and 2 of those were systematic reviews. They even said for certain things like otitis media, then the modest effect did not justify treatment, with a number needed to treat of about 7 or 8. And obviously with a recognition of the adverse side effects of treatment and the concern about rising antimicrobial resistance. The other point they made was if meningococcal disease is suspected, then giving early parenteral antibiotics with either intramuscular benzopenicillin or 3rd generation cephalosporin is of paramount importance. Moving on to the management by the paediatric specialist. So in secondary or tertiary care, you should be performing the following investigations in those younger than 3 months who present with a fever. So they should get a full blood count, a blood culture, a CRP, a urinalysis, a chest x-ray if there are respiratory signs, and a stool culture if the child has diarrhea. And then you should be performing a lumbar puncture in the following children if they have fever, unless obviously it's contraindicated. So if a child is less than 1 month, because they're at particularly high risk, all infants 1 to 3 months who appear unwell, and those 1 to 3 months who have a white cell count which is either low, less than 5, or greater than 15. And that was amended in 2013. And the reason for the particular focus on the less than 3 months old is that we know that even though it's a relatively uncommon thing in young infants, when it does occur, there's a higher risk of serious bacterial infection than in older children. The statistics there would suggest that basically in this hospital episode statistics, they suggested that the incidence of serious illness was 19,000 per 100,000 in those less than 3 months versus 1,400 per 100,000 in those less than 5 years. So a very, very significant difference. And depending on the data series that you look at, the incidence of serious bacterial infection in this age group lies somewhere in the range of 6 to 10%, so very significant risk. And again, because we know that this group are particularly high risk, the NICE guideline wouldn't recommend basic, just observation. They would want basic investigation as well as observation. And those in the high risk group, so those are neonates, or those who appear unwell, or those with a high white cell or low white cell count, should also be investigated for meningitis and receive empirical parenteral antibiotics, as they are obviously at the highest risk. Disappointingly, as is one of the bugbears of paediatricians, is they were unable to recommend a specific cut-off value for a CRP in terms of either treating or investigating further with a lumbar puncture. But they expected paediatric specialists to use the CRP result as part of their overall assessment of a child with fever. In terms of treatment itself, then obviously a lumbar puncture should be performed without delay and whenever possible before the administration of antibiotics, depending on how unwell the child is. And then antibiotics should be given to all children younger than a month with fever. It should be given to all children who are 1 to 3 months with a fever who are unwell, and those 1 to 3 months with a low white cell count or a high white cell count. So the NICE team then looked specifically at children aged 3 months or older, and they reviewed the predictive value of specific tests in detecting serious illness. So they looked at white cell count, absolute neutrophil count, CRP, procalcitonin, ASR, urinalysis, lumbar puncture, chest x-ray, and then a combination of those. And just a brief point on CRP versus procalcitonin. Procalcitonin is emerging as a very good test and is thought to be excellent at discriminating between viral and bacterial infection and between localized and invasive bacterial infection, and it becomes elevated much sooner than CRP, often within 6 hours of infection. However, the guideline group noted that the data comparing CRP and procalcitonin showed a statistical difference in favour of procalcitonin, but they were also aware of the small absolute difference, the low quality of the data, and heterogeneity between the studies in terms of settings and populations. And their conclusion, therefore, there was no clinically important difference between them, and therefore the CRP should still be recommended and PCT, procalcitonin, should not. Some of this came down to the fact that procalcitonin is primarily used in research settings, and also it's a more expensive test. So if we look at the recommended tests in specific groups according to the traffic light system, so a child between 3 months and 5 years who has 1 or more red features should have as a minimum a full blood count, blood culture, CRP and urine tested. If they fall, this same group with red features, should then also, a decision should be made about whether they should have a lumbar puncture, they should have a chest x-ray, irrespective of the temperature, the body temperature and the white cell count, and then also serum electrolytes and blood gas. And then the group without an apparent source of their fever, who have 1 or more amber features, should then have the following investigations done unless they're deemed unnecessary by an experienced paediatrician. So they should have a urine done, bloods looking at their full blood count, CRP and blood cultures. A lumbar puncture should be considered if they're less than a year, and a chest x-ray if they have a fever higher than 39 or a white cell count greater than 20. An important thought is the evidence for observation in hospital, because we do tend to observe febrile children for a period of time in hospital, see if they will improve or potentially get worse. And again, there was limited evidence, so they had to use a Delphi consensus for this, and their consensus agreed that a period of observation in young children was useful in differentiating those with a minor illness from those with serious illness, and they thought that it was actually likely to be cost effective for the NHS, as in the cost of the observation outweighed the savings from preventing unnecessary tests in a minor illness. However, they couldn't agree on reach a consensus on the duration of the period of observation, and they did, however, state that this would not be recommended for children less than 3 months, as observation alone may miss serious bacterial infection in this group. A brief look at antipyretic interventions. So a lot is already known about the physical interventions for reducing temperature and which ones work and which ones don't. But again, they state that tepid sponging is not recommended. Children with fever should not be underdressed or overwrapped. We should be considering using paracetamol or ibuprofen in children with fever who appear distressed, but we should not be using antibiotics with the sole aim of reducing body temperature in children with fever. It's all about relieving distress. And again, so these last three have been new to the guideline in 2013, and we should obviously only be using them as long as the child is distressed. Consider changing to another agent if the distress is not alleviated. Don't give them both simultaneously, and only consider alternating if the distress persists or recurs before the next dose is due. An important point is the response to antipyretics, which is often something that worries the parents in particular. And unfortunately, the evidence in this area was very low quality with poor study design, and the studies were quite old. And so when a child has been giving antipyretics, we shouldn't rely on a decrease or a lack of decrease in temperature at 1 to 2 hours to differentiate between a serious and non-serious illness. However, if a child has amber or red features, in order to detect a possible clinical deterioration, they should obviously be reassessed after 1 to 2 hours. And then a brief point on treatment. Empirical antibiotic treatment should be directed against the common organisms in children with fever and suspected bacterial infection, so Neisseria meningitidis, Strep pneumo, E. coli, Staph aureus, and Haemophilus influenza type B. A third generation cephalosporin is an ideal choice until your culture results are available, and in an infant less than 3 months, then you should be adding in an antibiotic that has activity against listeria, such as ampicillin or amoxicillin. And we should be referring to local treatment guidelines when rates of bacterial antibiotic resistance are significant. If a child presents particularly unwell, shocked, unrisable, or showing signs of meningococcal disease, then they should have immediate parenteral antibiotics. And we should be considering them for those who present with fever and reduced levels of consciousness. We should be looking for evidence of meningitis and herpes simplex and encephalitis, and giving IVA Soclavir if that is suspected. And then at the end of their 310-page guideline, they come up with a number of research recommendations, of which there are 5 main ones, which will hopefully help in the development and the updating of the guideline in the future. That a UK-based epidemiological study on the signs and symptoms of serious illness is undertaken, that we do a study looking at the validity of symptoms reported on remote assessment for children with fever. We do a study looking at the performance characteristics and cost effectiveness of procalcitonin versus CRP. Looking at studies on antipyretic medication in primary and secondary care to determine whether examination or re-examination is of